اوكي. بسم الله الرحمن الرحيم. الحمد لله رب العالمين وصلى الله وسلم وبارك على نبينا محمد وعلى آله وصحبه وسلم. Good afternoon and welcome you all to the continuous medical education. As usual, we are running now the fourth session of the series of the headache. And we already had approached the primary headaches, secondary headaches, and now we are approaching to the childhood headache, which is an interesting topic for all practitioners, especially in primary healthcare and our pediatricians. And the headache series today will be joined with our colleague, Dr. Akbar Mohammed. He's a consultant pediatrician, pediatric neurologist at Royal Hospital in Muscat, Oman. And he did his basic graduation and pediatric specialty at from the Postgraduate Institute of Medical Education and Research Center. And he did his pediatric neurology training at the prestigious All India Institute of Medical Science. And he works as a consultant pediatric neurologist at Aster also. And also in Cochin Kerala, also he's practicing there. And he's also looking after, postgraduate programs and training. And also he has a special training on ECG and in EEG and epilepsy. And also he's a member of international, Child Neurology Association and IACNA and other associations. And he's also looking after the neurogenetics and mitochondrial disorders. They have published some papers as international journals. Today's talk, as usually, we'll have the session of, there you have the chat place. So you have any difficulty in voice or anything, you can put it there. And you have also the Q&As. You can put your questions all through the talk. So we can answer it by the end. Also, this CME is almost be accredited for all participants who stay with us, inshallah, for at least 30 minutes. So the Zoom program usually calculates the amount of time spent by the participant here. And we'll send you, when you close the Zoom, you will get a link. So please fill up the evaluation forms so we can just send it to the OMSB for the approval for the certificates. And the talk will be around 45 minutes, and we'll get a chance to get questions. If anybody want to put a verbal question, he can raise his hands, and by the end we can let him also if want to get audio verbal questions. Dr. Mohammed, the ground and the playground is yours.
Okay, thank you. Thank you, Dr. Zahir. Yeah, assalamu alaikum all. Good evening, all of my colleagues and doctors in Oman. My sincere greetings. My thanks to Oman Family Medicine Society and Oman Neurological Society for giving me this opportunity in this forum. Right, since we have a mixed audience, we have family physicians, we have interns, we have residents, we have pediatricians and general practitioners. A small disclaimer that this particular presentation, I would just be focusing upon the basics and the core concepts of headache in children. So even before I go on to the topic per se, or I go on to the outline of my talk per se, let me just begin with a common scenario that we see in the OPD, right? So we have a 10-year-old girl. Just let's focus on this case and then we'll get into the topic per se, okay? So she has these episodes once every week for the last 2 years. She's 10 years old, but she's having this headache from 8 years of age. Most of these headaches in this particular child starts in the school hours, and the headache is slightly prolonged and severe. It lasts for around 6 to 8 hours. At the peak of these headaches, this child gets bothered by the sound in the school, the light, and she prefers to take a rest. Sometimes she does have occasional vomiting episodes with the headache, and sometimes this headache gets relieved after vomiting, or sometimes the headaches get relieved after sleep, okay? Most of the time she takes only paracetamol for her headache and it relieves her headache. And there was a similar history of such headache in her mother as well when she was herself a teenager. Now this is such a common scenario. So, but then what happens is that for the same child later on, there is increase in this number of episodes. So the last 4 to 5 months, she's having more number of episodes. It is becoming more frequent. She's having almost around 4 to 5 episodes every week, okay, from her baseline. But even though she's well in between, but this headache is sort of affecting her. She's not able to go to the school, okay. The family gets really worried after this, and they go to a physician in private, and neuroimaging is advised for this child. Now, this is a common scenario. Whoever has been handling children with headache, whether in private practice or in a primary healthcare setting, okay. So the parents are really concerned when the headache changes its pattern and it sort of increases in its frequency. So how do we approach such a scenario in this particular child, right? So as a physician, what are my options? Should I reassure the parents about these common headaches? Should I just proceed with the neuroimaging and, so that we are reassured that there is no serious causes? Should I proceed with checking the refraction error in these eyes, or should I just continue giving NSAIDs for this child for headache control? Or should I refer this child for pediatric neurologist, right? So these are some of the options that I have. So as we all see, this is the topic for today, headache in children. So my topic is going to be very simple and only focusing on the basic concepts, okay, of how do we clinically approach a child presenting with headache in the outpatient setting, right? So I would just focus on three main themes in this particular talk. So the case that we had seen, taking that case as an index case, I would like to talk about the core concepts of headache with an acronym called head pain, okay? So we will see all the concepts related to pediatric headache with this particular acronym. And just to make sure that I tell you that pediatric presentation can be different from that of adults. So I would just like to highlight you with 1 or 2 unusual scenarios. And then we'll inshallah try to end the session with a Zoom polling session with some interesting case scenarios, okay? Right, so what is this head pain acronym, okay? So how does it stand for? I just thought of making it interesting, so I made this acronym for this particular presentation, okay? So HED stands for head pain is common in children. So let us see how it affects children. What is the burden of headache in the world? And E stands for we need to inquire about the pattern of headache symptoms in the child, okay? And with the pattern, we would definitely have some idea about what is the type of the headache the child has. And once we know the pattern, we need to analyze whether the headache is primary or secondary, that is A. And D is that you should not miss the red flags. Don't ever miss the red flags for secondary headache. So the initial part is about the diagnostic aspect of a headache, about primary headache, secondary headache, okay, the pattern of headache. And the second aspect, that is pain, we'll just discuss about the management. So P is prophylaxis about migraine. So I'll be discussing about some of the prophylactic options for migraine. And how do you assess the symptom progress after treatment with the help of an headache diary, okay? And general measures of lifestyle and how it can improve the headache in children. And some non-pharmacological measures that we can try in children, okay? So this is the outline that I would be talking today. So let's go to the first one. So headache is common in children. All of us, including me, myself, and all our colleagues, all of us have headache, isn't it? So headache is such a common symptom. And headache is usually multifactorial. There could be a stress at home. There could be stress at the workplace, okay? You may have skipped your breakfast. So all of us have headache and children are no exception. But unfortunately, children are grossly underdiagnosed and undertreated because they do not express their headache like adults, okay? So it is said that almost more than half of children above 7 years of age have at least one episode of a severe headache. And less than half of children can have one episode of severe headache, especially smaller children less than 7 years of age. Now, these untreated headache episodes definitely affect the quality of life in children. So for we adults, the quality of life depends upon our work and our home. And for children, the quality of life depends upon their play activities and participation in the community, you know, about their normal routine at home. So these can be affected, and it is grossly unrecognized how the quality of life of children is affected because of headache, right? But there are many studies which has been looking onto this about the quality aspect of quality of life of children, and they have almost have a conclusive evidence that an untreated headache definitely affects the child's life, okay? So among the headache, the commonest headache that we all come across, or the common headache which usually comes for our routine practice for treatment purposes, is migraine. So how common is migraine? Okay, so if you say overall headache is common, but then how common is migraine? Is migraine a disease of adults, or is migraine also common in children? So you would be surprised to know that migraine is also common even in younger children. Like we in Royal Hospital or we in pediatricians usually handle children less than 12 years of age. So almost 1 in 10 children of age around 10 years can have a migraine headache. Okay, so it is roughly a prevalence of around 10% at 10 years and 20% prevalence at 20 years. It is easy to remember. So 1 in 10 children of age 10 years is affected with migraine, and 2 out of 10 children, 2 out of 10 young adults of 20 years are affected with migraine headache. So migraine is also one of the top 4 chronic diseases in children after asthma and epilepsy and cancer. So we may think that we focus our resources on treatment of asthma and treatment of epilepsy, but migraine is also a chronic condition which can affect children for a longer duration of time. So 1 in 10 boys or 2 out of 8 girls, okay, when they grow, they continue to have migraine as adults and they suffer long term. Okay, so 50% of them outgrow their migraine symptoms by childhood, but there is a significant proportion of them who carry on these symptoms as young adults and they continue to suffer from migraine headaches. So in terms of the years lived with the disability, migraine is the second common cause after a low back pain to cause, a disabled life. So you don't want a child with a disabled life. So this is something that we want to avoid as well. Okay. So if you look at the overall prevalence, again, to reinforce the fourth point that migraine is also common, but in very small children, like especially children less than 6 years and 7 years, it is the non-migrainous headache, which is much more than the migrainous headache. So this particular population are very small, like a 3-year-old, 4-year-old, 5-year-old, and 6-year-old. You are worried about non-migrainous headache, which could be a secondary headache or a serious headache as well. Okay, but in bigger children, headache, the migrainous headache is much more common than that of a non-migrainous headache. So having understood that migraine headache is common and headache as a common symptom, how do we approach these children? So we have to go systematically, okay? And the first approach to go systematically is to inquire about the headache pattern, okay? So what I mean by the pattern, okay? To understand the headache pattern, what we do need in an OP setting is a paper and a pen, okay? We need to talk to the parents, take a good history, okay? Make a graph out of it, right? So you would be surprised that even 25 years ago, okay, the classical paper from Rothner mentions that how we need to assess the different patterns of headache, and universally there are usually only 4 different patterns of headache. Okay, so either it is an acute headache or it's a chronic headache, and if it is acute, it could be acute and a episodic headache as shown by these blue lines, and this is one of the feature of your primary headaches like migraine headache or tension headache, which is acute but is also episodic, characterized by symptom-free intervals. The child would be well in between. But you can also have a headache which seems to be having for longer duration of time in terms of weeks and months, okay, and it can affect the child. And if it is chronic, either it can be a very progressive headache, which is a very dangerous one, as you can see in this maroon line, and the symptoms can increase over weeks or months, okay, and it can affect the child life also in some cases, right? Or it can be a chronic headache, which is almost there daily. On top of it, there is like intermittent, like acute on chronic exacerbations type, like we call it an asthma. So we have like a chronic baseline headache, and on top of it, there are intermittent exacerbations, okay? So this is usually the pattern of a chronic non-progressive headache. So in acute, we have 2 types of headache, an acute and episodic headache, and an acute and a very rapidly progressive headache, okay? And you can have a chronic headache, which is progressive, or a chronic headache, which is non-progressive, okay? So one of the first goal of a history taking is to understand these patterns. So we may need a paper and a pen, and you try to draw a graph, ask about the months, what happened in June, what happened in July, what happened in August and September, try to understand the number of days a child is affected by a headache, okay? So this is important because your differentials is based upon this particular pattern recognition of headache in children. So what could be the differential diagnosis? So if a child has acute and a recurrent episodic headache, as I told you, primary headaches are the #1 differential. So primary headache includes migrainous headache and tension headache. These are the common ones. The rarer ones can include cluster headaches and cranial neuralgias, which are absolutely rare in children. Okay, but the common ones are usually migraine and tension headaches. Okay, but if it's an acute headache but seems to be rapidly progressive and leads to multiple symptoms in the children, the common things that we usually think about is a CNS infection. And the commonest cause of a very acute rapid headache causing a child to present in the emergency room is viral meningitis or viral meningoencephalitis, okay? But you can have a dehydration, dyselectrolytemias, acute hypertension, okay, sudden traumas or a sudden stroke, also presenting as acute headache, usually along with other systemic signs to the emergency room. If you have a chronic and a progressive headache, and this is this category that we really don't want to miss, that's why I have put in red. The one of the category that we are worried about is not to miss a brain tumor or raised intracranial pressure syndromes, either because of a brain tumor or otherwise, where it is called as an idiopathic intracranial hypertension. And you can have a slowly developing hydrocephalus or a chronic hypertension or slowly progressive vasculitis presenting as a chronic and a progressive headache. So these are some of the common differentials that I put. The one that I put in red usually indicates the serious ones. So if you have like a chronic baseline headache affecting the child for most of the days, almost like a daily headache, and having intermittent exacerbations in between, we think about chronic migraine. Okay, so even migraine can present chronically, okay, in addition to being present like acutely and episodically. Or we think about a chronic tension headache. So these are the two common disorders which presents as a daily headache or almost like a non-progressive chronic headache. But there are significant amount of proportions of teenagers and young adults more than 8 years presenting with childhood stress, okay, childhood conversion disorders, childhood somatization disorders. So this is another category, the psychological causes of headache, which you need to think about. You need to go back and look at the stressors if you're handling a child with a chronic non-progressive headache. Right. So just come back to our own case. So this 10-year-old girl, as you can see, is having headache for the last 2 years. So we definitely know that this is a chronic headache, and we definitely know that she's having only episodes once a week. So she had a chronic episodic headache, which became almost like a chronic daily headache pattern for the last 3 to 4 months. Okay. So this is one of the typical pattern of a chronic non-progressive headache. So there is a change in the frequency, but despite the change in the frequency, the child is still well in between. Okay, she can still attend her school, but there are some days where she does not go to the school. So this type of history understanding is very important. So likely this child had an episodic headache, which has now become into a type of a chronic daily headache. So understanding the pattern is the first step, and this child has a chronic non-progressive headache. So the next part is to understand whether this headache is primary or secondary headache. So if you look at the recent classification of headache from 2018, the International Classification of Headache Disorders, the third classification of ICHD type 3, one of the important aspect from the history taking is to bifurcate history of the headache etiologies into primary headache syndromes and secondary headache syndromes. I'm sure we had a lot of sessions among adults about primary headaches and secondary headaches. Let us look at how it differs from that in children. Okay. So what are primary headaches? Primary headaches do not have any insult to the brain. Okay. Most of them are idiopathic. Most of them are because of unusual intrinsic causes within the brain, which affects your pain modulating mechanisms. I'm not going into the pathogenesis behind a primary headache, but what you understand is that there are some intrinsic mechanism which causes, your cerebral cortex, your brainstem, and your vascular structures in your brain to behave in a funny way. There is vasodilation, and there is like release of inflammatory peptides, okay? And that is the reason these children would have these episodic phenomena. So despite like 50 years of research into migraine and 50 years of research into tension headache, nobody actually can say what is the reason for a primary headache in a confident way. But what we know is that these are mostly idiopathic because of some intrinsic mechanism. The classical examples are migrainous headache and tension headaches. But secondary headache is when your sensitive structures, pain sensitive structures like your dura, the blood vessels, the meninges, or your teeth or your ear canal are affected by some sort of injury. Okay, so the dangerous ones are of course brain tumor, stroke, vasculitis, and idiopathic intracranial hypertension, and so on. Okay, so in order to understand that, right, how to understand what causes a primary headache and what is the reason for a secondary headache, a very good history taking is must. Okay, but we are definitely faced with challenges in a children. Okay, so like for any symptom, like let it be pain abdomen or vomiting or a fever, okay, any symptom analysis focuses on what is happening to the symptom per se. Okay, like how it starts and how it progresses. The onset and progression of a particular symptom is very important. And the same holds true for headache as well. one of the most important point that you should understand is how the headache starts in the beginning. Okay, like if you have a very dramatic onset of headache in the beginning, you think about vascular causes like intracranial bleeds or meningoencephalitis, right? But if it's like a very gradual and insidious onset, slowly progressing, you think in terms of chronic disorders like ICSOL or a primary headaches like migraine, which sometimes can have a very insidious onset, but then later on has this characteristic pattern of episodic presentation. Okay, so once you understand the onset for a pain, you need to describe the pattern. Just now we discussed about various patterns, like you can have an acute progressive pattern, acute episodic pattern, chronic progressive pattern, and a chronic non-progressive pattern. Okay, and sometimes in children you have mixture of this a chronic episodic pattern on top of a chronic daily pattern as well. Okay, so you need to understand the pattern. The other questions when we ask the parents, okay, of where does the child localize the headache, okay, and how is the nature of the headache, it is almost impossible to derive at good answers, because the parents just observe their own kids, and they try to understand, okay, probably the child is having a headache in the forehead or in the top of the head. Okay, but it is a good rule always to talk to the child directly, especially if the child is more than that of 6 years. Okay, you need to use non-threatening maneuvers, you need to use some toys. Okay, you need to demonstrate like a heartbeat. Okay, or do you feel headache like a heartbeat? Okay, you may use a belt over the child's hand and show, okay, is it like a belt tied over your hand? Okay, so you need to be a little bit more imaginative, okay, and ask how the child feels the headache. But sometimes the children may be able to give you very good intelligent answers, but some children may not be able to express their headache, but they may be able to actually draw their headaches. Okay, if you ask them to go and say, okay, you come back like 2 months later with how do you feel about your headache, they may come with reasonably good drawings about how they feel about their headaches, and that can give good clues about the nature of headache. Okay, in order to understand the pattern of headache, it is a good idea to ask the parents to document the headache with small diaries like a log. Okay, so I'll talk about the headache diaries in further slides, but the more you document, at least for 1 or 2 months, the more idea you have about the pattern of the headache. Okay, but sometimes how a child feels, okay, with the headache, we have to infer from the behavior of the child. Okay, that's very important to understand what the child does with the headache. So the 5th question, which I put in red, is very, very interesting and very, very important. Okay, so you may have parents who are like who definitely say, my child is having a very severe headache, he's affected by this headache, he's very bad most of the time. But when you ask, what does your child do when he has an headache, they may say nothing. He just sits with us, he talks with us, he watches the TV, he plays with his mobile, he plays with his sibling, but he always says he has headache. So the moment you know that the child can do his routine life, can study, can play in a mobile, can play football with his siblings, okay, can watch a TV, you know that the child is not affected by a severe headache. But the moment you know that the child is extremely cranky and crying, okay, or like sleeping up curled in one place, okay, trying to avoid lights, okay, is keeping quiet, or has become pale, is having like dark circles and is refusing to feed, or is having behavior like going and banging the head in the wall or pulling the hair, okay, you know that the headache is a severe headache. So in children, it is sometimes important to infer the nature from the headache behavior rather than asking question like, is it like pulsating, or is it like stabbing, or is it like squeezing, etc. Okay, so having said that, this is one of the challenge as a pediatrician and as a pediatric neurologist you would feel by taking the history about the nature of the headache. So it is most of the time very difficult to understand the nature. Then you need to ask about how long does the headache last, okay, whether it lasts for minutes or lasts for hours or lasts for seconds. So usually you don't have a headache which is lasting for seconds. Sometimes you can have unusual cranial neuralgias which last only for minutes. But if you have some unusual phenomena lasting for seconds or minutes, you should question the diagnosis of headache. It may be some form of a sensory seizures, okay, which is manifesting like headaches. Usually headaches manifest mostly in terms of minutes or hours rather than seconds, okay, or minutes, okay. So this is the question that we ask about the nature of headache. So once you have asked about the symptom per se, the headache symptom per se, you need to ask about the associated symptoms, okay? So you need to know whether the headache is associated with other autonomic symptoms like vomiting, pallor, okay? Like avoiding light, avoiding sound, okay? Unusual, avoiding smells, okay? Unusual sensory phenomena, whether it is associated with numbness, okay? Whether it's associated with a warning sign like an aura. Some children can say that they may feel funny sensation in their eyes, like half an hour to 1 hour before they have an episode of headache. Especially bigger children, more than 10 years, can say about something like an aura. And as I said, if they are not able to describe a particular feeling, some of children can actually draw and express their feelings as well. Okay. So the associated symptoms may be non-neurological as well, like a pain abdomen, okay, or like can be like back pain, leg pains. So which can actually favor a somatization, okay? If the child is complaining of pain in multiple areas of the body, in addition to headache, in a bigger child, you may think about psychological issues as well, okay? So here you can have, especially girls around 8 to 10 years may complain of dysuria, or they may complain of lower abdominal pain, where you can even think about child abuse or sexual abuse as well, okay? So you need to be, extensive in your headache history. You need to see the child as a whole and the family as a whole, and you need to characterize how it affects the child, okay? So the last 3 questions are very important, especially the questions whether the child gets up screaming at night with headache, okay? So if a headache affects the sleep and the child is not able to sleep properly with the headache, it's most likely a serious headache, okay? Or if the child wakes up with headache in the morning, and if the headache is very severe and the child becomes pale and refusing to feed and has vomiting, it could be a severe headache as well. The presence of convulsions along with headache is usually a serious sign, okay? But there are associations of migraine along with epilepsy per se, but still if you have convulsions, you should always think about a secondary cause for that particular headache, okay? So is there any diet or any food that actually triggers migraine? It may be very difficult to identify from children, but if the parents categorically say that this particular food like cheese or grapes or Coke or coffee causes headache, okay, it's a good idea again to ask the parents to make a diary for like 1 or 2 months, okay, and let them note that this particular food causes headache, okay, in the diary. And once you have confirmed that this particular food causes the headache for the child, you can ask the parents to avoid that particular food, okay? So you need to ask about the triggers, okay? So some children have this trigger about playing the sunlight, okay? So sometimes wearing dark sunglasses, okay, would help them to avoid a migrainous headache attack, okay? So as I told you, the challenges in children are many. Especially we need to infer from their behavior, okay? The parents may not be able to describe the nature of headache. So here the headache drawings and headache diary are very, very useful, and sometimes even mobile video recordings, okay? You can ask the parents to do mobile video recordings and come and back and discuss how the child looks like during a headache episode, okay? So that can give a clue, okay? So quickly, let us see about primary headaches and secondary headaches. So characteristically, tension headaches have a dull aching feeling over the forehead, whereas migrainic headache characteristically are unilateral and having a pulsating like a heartbeat like quality or a pounding like quality, okay? So the classical features of migraine is that it is always moderately severe, okay? You cannot have a child with mild migraine attack. It is usually if the child, retreats and goes and sleeps quietly or is extremely cranky and crying, okay? So it's a throbbing, pulsating or a pounding headache. You need to have at least 4 or 5 attacks of such headaches to call it, as a migraine. And in children, it can last for small hours. In adults, usually we use the cutoff of around 4 hours to have a migraine attack. But in children, the migraine attack can be as small as 1 hour as well, okay? And it can last for like continuously for 3 days as well. Children can have bilateral migraine headache as well. And when compared to that of adults, it's usually unilateral, but children can usually have, it is poorly localized. They may complain over their forehead, over the middle of the top of the head, and sometimes even their back, okay? But one thing which is very important is that the child cannot do his routine activity, okay? So it is aggravated by his physical activity, and the child is bothered by sound, light, smell, okay? And the child prefers to sleep in a dark room. And another important point which helps us in the diagnosis of migraine is the family history. So most of these parents or cousins especially from the mother's side, okay? And of course from the parent side as well, father side as well, can have history of any form of headache. Okay, it's not just migraine headache as well. So you need to characterize the history of any form of headache. For example, if you ask the mother and father, do you have migraine? Most of them say, no, I don't have a migraine headache. But if you ask, go into the details of their headache of the father and the mother itself, okay, you would be surprised that some of them have the typical features of migrainous headache as well. Okay, there's a strong family history in most of them. If there is no family history of migraine in the cousins or in the parents, okay, you should sometimes doubt your diagnosis of migraine, and you should be aware of migraine-like mimics. Okay. So migraine with aura is almost very rare in children. Only around 2 out of 10 children with migraine, that is 20%, may have some aura, and the commonest aura is usually vision aura, okay, where they can see some funny lines around the light, which is called as a scintillating scotoma or a fortification spectra. Some of them can see an enlarged blind spots as well, okay. But the aura is rare, but is usually prolonged around 5 to 30 minutes, sometimes up to 1 hour, and the child develops the headache, okay, when the aura is like present, okay. So it's usually within the middle of the aura, the child starts developing a headache, okay. And so the aura starts first, and then the headache starts in a case of a typical migraine with aura, but it is usually very rare in children, okay. So these are again the graphical presentation of what you mean by phonophobia, photophobia, and this is how children, you know, show how they feel, like hitting the hammer in the head, okay, or like a tape over the forehead and so on, okay. So among the triggers of the headache, the top 4 triggers is what we commonly see. And as you see, the video games, mobile games, watching TV, okay, sunlight, a warm climate, which is very common in our part of our country, okay, lack of sleep, which can be common in bigger children and teenagers. These are our top 4 triggers of children with migraine. As much as possible, we need to educate the family to avoid these triggers. So as I just highlighted, there are certain features unique to migraine in children, like behavioral features. Sometimes the nausea and vomiting can be much more than headache. So in children, they can have these atypical migraine variants or episodic syndromes, okay, like with the cyclical vomiting syndrome, or like just with pain abdomen, okay. So you can have a periodic syndromes or acute episodic events, even without a headache, with predominant gastrointestinal manifestations as well, okay. So this is a very tricky group where you need to think about sometimes even about epileptic seizures or certain rare channelopathies like episodic ataxias, or rare metabolic conditions like porphyria as well, okay. So you can have these episodic syndromes with the gastrointestinal manifestations rather than having neurological manifestations as well, okay. Aura is usually underreported in children, and children usually tend to have more bilateral headaches than unilateral headaches. So this is a series of headache drawings, okay, like having a tight tape, which actually indicate the child is having a tension headache. And this child here is drawing a fire in the localized part of the occiput, or a bubble in the occiput. Such a localized drawings is very, 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 very suggestive of a local lesion, like a space occupying lesion in the brain, okay. The drawings like showing a hammer or hitting in the one side of the head, okay, indicates usually a migraine headache. And this child is showing like a factory sound that I cannot bear the sound because of headache, okay. So again, suggestive of a migrainous headache. So this is the classification of migraine. As we said, children mostly have migraine without aura. You can have a chronic migraine, as I showed in our index case, when you have more than 8 migraine days in a month, okay, you can think about chronic migraine. You can have complications of migraine, okay, like having ophthalmoparesis, or like having a prolonged migraine more than 3 days, where you call it as status migrainosus. Again, I'm not going into the details. And episodic syndromes with migraine are common in children. This is very, very important, like cyclical vomiting syndrome, like abdominal migraine, paroxysmal torticollis, and paroxysmal vertigo. So the other common primary headache is a tension headache. It's a very mild headache, and it's exactly opposite to your migrainous headache, in that the child would feel some heaviness in his head, okay, usually over the forehead, but it is usually infrequent episode. It's usually less than 10 episodes in a year, okay. But the episodes can be very prolonged. It can last for 7 days, you know, sometimes even 8 to 10 days as well. Okay, the child can continue his physical activity. He can still go to school. He can do his homework. He can play. Okay, the child can be distractible. There is no autonomic phenomena like phonophobia, photophobia, osmophobia. Okay, the child can have some sort of tightness over the neck muscles. Okay, it is usually related to a stress. Okay, it may be a physical stress, or it may be a psychological stress at school. Okay, but again, the pathogenesis is not clearly understood in a case of a tension headache. So the other thing that we are worried is the secondary headaches. So we have seen primary headaches. The primary ones are migrainous headaches and tension headaches. But the most scary one is always the secondary headaches. I have a personal experience of a child whom I strongly thought it was a migrainous headache in a 7-year-old boy, with a strong family history of migraine, but later on turned out to be a medulloblastoma, right? So we are always worried as physicians, as neurologists, even the family is worried, is there something which is in the brain which is causing these symptoms, okay? So how do we understand these secondary headaches? So secondary headaches, unlike your primary headaches, is usually very constant, okay, and the child is unwell, okay. The child would have like sleep headaches, would have headaches on awakening, okay. He would have refusal to feed, right? And any child usually less than 6 years of age, it is better to keep in the mind about secondary headaches, okay, and better to rule out secondary headaches before labeling them as migraine. Even though children less than 6 years can present with migraine, especially if there is a strong history of migraine, but it's better to be careful about secondary headaches in smaller children, okay. And it is usually a constant type of headache, and it can be associated with other neurological symptoms like seizures, ataxia, vision complaints, new onset squint, okay, and so on, okay. But interestingly, if your intracranial hypertension is slowly progressive, okay, over weeks to months, it can actually closely mimic migraine. So idiopathic intracranial hypertension is another migraine mimic, which is very tricky, okay. It can closely mimic migraine, and so that is one of the reason. Even the American Academy of Neurology recommends that even if you have an acute episodic recurrent headache, okay, if there is no family history of headache, it's better to look for the fundus to rule out a papilledema, okay. So the slowly intracranial hypertension can be a very close migraine mimic, okay. The examination of the child is definitely done to rule out primarily your secondary causes. So a close and a careful examination is required at all levels, especially at the primary healthcare levels, where we are focused on the vitals and the BP. So if you ask me what are the two things that you need to always look in a child with headache, it is the BP and the fundus, okay. So these two things always has to be looked in every child with headache, okay. So the high BP may be missed in a case of an headache, okay, it can give a clue about hypertensive encephalopathy. The pulses can go, if it's asymmetric, can give a clue about like Takaisu arthritis or unusual vasculitis. Obesity can give a clue about idiopathic intracranial hypertension. A very low weight can indicate malignancy or tuberculosis. Fever and it can indicate meningitis. Pallor can indicate malignancy. Skin lesions can indicate neurofibromatosis, like we can have capillary spots. If you have unusual traumas, okay, unusual traumas, like if you are seeing something unusual, skin lesions, like I had a child with multiple cigarette butt injury, okay, it was a case of a non-accidental injury, okay. So it looked like always the parents used to come with the child is having recurrent skin allergies with headache, when actually the child had been abused by the parents with multiple cigarette butt, lesions to the skin. So if you see, unusual injuries to the eyes, like subdural bleeds or subaponeurotic bleeds in the eyes, like raccoon eyes, okay, you can think about non-accidental injury or trauma. If you have hirsutism, you can think about idiopathic intracranial hypertension or an hypothalamic brain tumor. You should always check for sinus tenderness, which is your Muller sign, and the ear to rule out the otitis media. The neurological examination is primarily focused upon fundus, where if there is papilledema, it can suggest raised ICT, but be beware, almost like 2 out of 10 children may not have papilledema early, okay. So fundus can be normal early in the presence of raised intracranial hypertension. So you should have a very high index of suspicion if you're thinking about a raised intracranial pressure. Retinal hemorrhages can indicate, again, a non-accidental injury, especially if the child is small, like an infant. Or if you have children who are like helpless, like especially children with cerebral palsy or children who are disabled and non-ambulatory, children with complex neurometabolic disorders who are taken care by their mates or parents can be subjected to child abuse, okay. So if you see retinal hemorrhages in the fundus, you may think about child abuse. So squint is another indicator of a tumor or an idiopathic intracranial hypertension. Deficits, nuchal rigidity, ataxia, cranial nerve deficits, all of them can indicate secondary causes of headache. So when to do imaging for the secondary headache? So to be very honest, the major reason that we do imaging, or we are forced to do imaging in our OP setting is actually when the parents or the families insist for an imaging, okay? So that's what we see in private practice or in any practice usually, okay? But the guidelines clearly say that if you have a strong family history of migraine and if you have a very characteristic acute recurrent episodic headache, when the child is well in between, there is no indication to do any form of imaging, okay? Because what would happen if you do imaging for a child with migraine or a tension headache is that you may pick up certain incidental lesions, okay? So 5 to 10% of these children where an MRI is done can show incidental findings like arachnoid cyst or some white matter changes, which is not at all related to your primary headaches, okay? So as much as possible, if you are clinically confident about a diagnosis of primary headaches, please do not go for an imaging. But having said that, there are clear indications for imaging, especially if you have a child less than 6 years with a progressive and a severe headache. It's better to go for an imaging, okay? Preferably MRI because we don't want an ionizing radiation, okay? Avoid CT as much as possible. But if you have a headache with the focal deficits or a progressive worsening headache over weeks, you can go for imaging, right? So in addition to that, if there's a recent change in the headache pattern, okay? Like if you have episodic headache becomes a daily headache also, and if you have high index of suspicion of idiopathic intracranial hypertension, you can go for an imaging, okay? Children who are having occipital location, a constant occipital location of headache may sometimes have posterior fossa malformations like a Chiari malformation or a posterior fossa arachnoid cyst, and they can also go imaging. If you have the severest thunderclap headache, which is the worst headache when somebody has an intracranial hemorrhage, though luckily not seen in children, okay? Again, you can go for an imaging. So these are some of the indications for imaging. Preferably it's MRI, okay? So what imaging has to be done? Again, there are clear guidelines from American College of Radiology. As I told you, for primary headache, there is no imaging, but for secondary headache, it is MRI brain without contrast. But if you feel a suspicious lesion, if it's like a tumor, you can go with the contrast, okay? If it's a severe thunderclap headache, for bleeds, even a CT without contrast is enough in your emergency setting or casualty setting, okay? If you're thinking about meningitis and meningoencephalitis, you need a MRI brain with contrast. And if you think about headache just due to trauma, you can go for MRI brain without contrast. So when you need to refer to a pediatric neurologist. So the NICE, there is no guidelines, but there are NICE from the UK group, National Institute of Clinical Excellence, does suggest its recommendations, and all the recommendations are what we had just discussed. All children less than 4 years has to be preferably seen by a pediatric neurologist, okay, for neurological assessment, primarily because they can have secondary causes for headache. And if children are less than 12 years, okay, and if there's all these red flags that we have seen, if the child wakens up on night, if there's headache in the morning, or headache with cough and posture, okay, headache with vomiting, headache with ataxia, headache after within 5 days of injury, you can refer them to a pediatric neurologist, okay. So a quick summary about primary headache versus secondary headache. Primary headache is episodic. It's usually frontal or temporal. The child is normal in the inter-episode interval, okay? And their family history can be positive. Whereas in a secondary headache, it is progressive. It is constant. The child is unwell, okay? And there is more vomiting than nausea, and you can have other neurological deficits, okay? So these are the differences between primary headache and secondary headache. So now coming back to our own case, as you can clearly see, had headache for 2 years. It was episodic headache happening only once in a week, and then it became more sort of constant. So this child has likely as a primary headache because there is also a strong family history of migraine in the mother as well, okay? So this child likely has a chronic migraine. So the next important point D is that don't miss the red flags. So we have already highlighted. So when you're not supposed to miss the red flags in headache. So any new onset headache, which is severe and progressive, very focal headache, which is occipital, okay, a headache which is with posture, okay, or with coughing, with sneezing, with urination, okay, with pressure. If the headache increases, okay, you should think about raised ICT like straining or Valsalva maneuver. So these are some of the red flags, okay. And if you have abnormal neurological examination, headache which is on night, which is on awakening, okay, and headache associated with systemic disorders or immunosuppression are supposed to be the red flags, okay. So there is a very interesting mnemonic, Snoopy, given by AN, okay, which says that these are the headaches as for systemic signs like immunodepression, malignancy, and so on, and presence of any neurological associated signs like seizures or squint or ataxia or diplopia, right? Onset if it is sudden, or if the child has an occipital sort of a headache, okay, older age and younger age, less than 3 years. And if you have like 5 P's, previous, okay, headache which is changing in pattern, progressive headache, headache by pressure, okay, and headache with postural components and headache with pregnancy, okay. So these are some of the red flags for your serious headache. So does our child has a headache? Our child, our index case does not have any red flags, okay. She does not have any neurological symptoms. She does not have a constant progressive headache. Instead, she still continues to have an episodic headache, which is much more frequent. And in the inter-episode interval, still she is fine. So our child has no red flags, okay. So having understood how do we approach, quickly we'll see how would we manage these children with headaches, okay, coming to our OPD. So prophylaxis should be started early, okay. So this is the message that I would like to give you. Why is it so? Why you should start prophylaxis, especially in a case of a migraine, okay? Because if it has been found, okay, through population studies and many studies suggest that the amount of school days that is lost or amount of participation days that are lost in children is much more. Like this study says that almost like 130,000 school days are missed every 2 weeks in case of United States of America, right? And it's also more likely that if you don't treat or don't try to treat a migraine, they may likely become a chronic migraine as an adult. So 1 out of 10 boys and 2 out of 10 girls, okay, when they grow up and adults, become a chronic migraine, okay. So the adolescents, okay, most of the adolescents, okay, usually tend to tolerate their headaches and they tend to report less to their parents. So it has been found out that almost 1/3 of the adolescents who meet their criteria, okay, for starting prophylactic therapy, still only 1 out of 10 or 2 out of 10 or only 90 to 20% of them are started on prophylactic medication. So you need to start prophylactic medications to improve the quality of life of the children, okay. So the goal is that the child should have less number of headache days and he should be able to participate in his school and social activities, okay. You don't want him to carry on his headache as an adult. So there are very clear recommendations of when would you start. So if the child has headache every week, if he has a moderate severely headache, which automatically means that he would have more than 3 to 4 headache attacks in a month, okay. And how we can understand this? We can understand this by asking the parents to document in a headache diary, or if the child has more than 2 headaches with aura, okay, at any point of time, or if the child is not having this much attacks, but even if he had a single attack in a month and if it was a very severe attack and the attack lasted for more than 2 to 3 days, okay, requiring emergency admission or hospitalization, it is better to start a migraine prophylaxis, okay. So there are the drugs for migraine prophylaxis are extrapolated from adult studies. This particular table column is just a short view about what drugs that we use in children, okay. I will be just briefly discussing, okay, like topiramate and propranolol and flunarizine, okay. But having said that, there are no much guidelines in children when compared to that of adults, okay. So there are many rigorous studies in adults which gives good level of grade A level evidence. But as far as children is concerned, we have more of only RCTs and we don't have much evidences about which agent is better, whether this agent is better or that agent is better, right? Having said that, okay, there are certain, medicines which are preferred in certain subset of children, okay? Like we had a trial called the CHAMP trial, which is Childhood and Adolescent Migraine Prevention Trial, okay, which was published in NEJM, and it had given more favorable response to topiramate, okay. And so over the years, as pediatric neurologists, we are more comfortable in starting topiramate, and we found its personal experiences much better responses in children, okay. Even though it is FDA approved for children more than 12 years, we tend to use in any child who's more than 6 years of age, okay. So the other drugs that we can think about is cyproheptadine, which is an antihistamine, and that works much better in smaller children less than 6 years, okay. And because it is also a very agent which promotes a good appetite, okay. But one of the problem with cyproheptadine is that it can cause sedation. So it is usually preferred in smaller children with migraine. Propranolol is out of vogue as far as pediatric neurologists are concerned. It is still widely used in adult medicine, but because this it can reduce the energy because children need to be active and playing around. Propranolol has some sort of side effects that it can reduces the degree of energy and physical activity in children, okay. It can induce depression and low mood. So there is conflicting evidence for propranolol, and topiramate is generally more preferred than that of propranolol, okay. So these side effects of these medications like either topiramate or cyproheptadine or sodium valproate or amitriptyline can be used as an advantage, okay. So if you have a very obese child with migraine, like it's better to start with topiramate because topiramate promotes anorexia and causes a bit of a weight loss. And if you have a very thin child with migraine, with the mood disorder, sodium valproate can be preferable because sodium valproate can cause some degree of weight gain. A child with a migraine with a mood disorder, again, sodium valproate may be preferable. A child who is having anxiety, depression, okay, you may start amitriptyline, but you may, of course, go for a psychological assessment and psychiatric assessment as well. Migraine in a very young, less than 6 years, cyproheptadine is preferred because it's an agent which can stimulate the appetite, okay? And children with insomnia, again, you can prefer amitriptyline, especially for bigger children more than 10 years. Children who have migraine and syncope together or orthostatic tachycardia syndromes can be started on propranolol. Okay, so probably the indication for propranolol is those who have syncope or tachycardia syndrome or highly anxious children, okay, with tachycardias, where propranolol may be of some help in reducing their anxieties. So when do we stop the prophylaxis therapy? So here we need to sit down with the family and give a clear plan. The plan is not to eradicate the migraine attacks completely, but we have to have a clear goal that, okay, the child is having this many attacks in a month, 6 to 8 attacks. Let us reduce to 1 or 2 attacks in a month. Okay, so we have to give a realistic goal, because one of the reason where the people don't like prophylaxis is that we are going to give it for a longer duration of period. Okay, like at least for a 6 months. Okay, and we're going to taper it very slowly. So families are generally thinking, what is the need to give a daily medicine when probably an abortive therapy which can give a quick result is much more helpful? Then we need to actually sit with them and discuss with them, telling that it's probably better to give these prophylactic agents, because on the long term, they make the children much better rather than giving multiple abortive medications and frequently, okay? It's not good. So you usually titrate very slowly. Like when we start topiramate, every 2 weeks we go up, okay, slowly. So we reach the full dose around 3 months of time. And once adequate response has been reached, we keep it for around 6 months. So the parents should be told this, okay? Should be told that it may take 2 to 3 months for the effect of these medicines to happen. Once the effect is reached and you have observed with the help of headache diary, you maintain it for a period of 6 months and then you wean it off over 1 to 2 months. So you should never jump on between one prophylactic agent to another. You should not rapidly shift between propranolol and topiramate and sodium valproate. You should try at least one medicine for at least 2 to 3 months, unless there is a severe side effects. Okay, if there are intolerable side effects, you can stop the prophylactic agent and you can switch over to the other agent. So if you see our girl, she has never been tried on any prophylactic agents all these years. So it's better to start this child on topiramate. Okay. So this child was then put on topiramate and then she did well. So one important message here is that we need to monitor and document the symptoms with the help of the headache diaries. Okay, the headache diaries are very useful. There are many studies all across the world which sees these advantages. So this is one such example of headache diary from Boston's Children's Hospital. Okay, which shows that what and all you can document in a headache diary. So when you ask this question, what happened just before the headache, you can easily document the triggers of the headache. Okay, that the child went for a play in the park, so sunlight. Okay, the child was studying for the examinations. Okay, the child did not sleep well. The child is more on the video games. Child is watching more TV. So the triggers can be documented in a headache diary. And if you ask how much the head hurt, okay, it's better to document with this phase scale. Okay, it would be surprising. Most of the parents would say my child is having severe headache, but when you ask them to document the pain scale, most of them would have a pain scale of 2 or 4. But so any pain scale more than 6, 8, and 10, okay, like the faces pain scale where the faces change into a grim face and a sad face and a crying face, okay, is much more moderately severe headache. So a pain scale showing 6, 8, and 10 is a moderately severe headache. And where is the headache and how long did the headache last and when did the headache end? Okay, so all these informations are very useful. One, to reach a diagnosis, and 2, to understand the response of our prophylactic medications, and 3, to convince the family. Okay, the family gets much better convinced when we use a headache diary. These days, there are mobile apps which are used in adult neurology. I have personally no experience with the mobile apps, and they are not validated for children, but there are many mobile apps which some of the parents find it easy to document rather than documenting in papers. Okay, so these advantages that we can prospectively document, we can understand the pattern, we can understand the aggravating factors. Okay, it reduces the recall bias. Okay, so and it improves your accuracy of your headache. Right, so right, so our child needs headache diary. Okay, so improving the quality of life is very, very important. So how do we do that is by focusing on the 3 pillars: the lifestyle, the abortive medication, and the prophylactic medication. So the lifestyle of these children, is very important. Children should have a good sleep pattern for around 7 to 9 hours. They should drink water around 1 to 2 liters. Okay. They should avoid coffee or tea. Okay. So usually you should only have coffee or tea for 3 days out of 7 days. Okay. Some sort of exercises, relaxation therapies, yoga, breathing exercises, thinking about good images, managing the stress goes a long way in improving the quality of the life. And if you find a specific trigger or a specific diet, you can ask to avoid such diet, and that can help the headache, right? So the abortive medications, nothing much detail. So as far as the evidence is concerned, we have evidences only for NSAIDs, that is Brufen and paracetamol. Okay. Unlike the adult world, the evidences for triptan is limited, and triptans are usually used for adolescents more than 12 years of age. So one important point about these abortive agents like paracetamol or Brufen is that they should be given within 1 hour of headache. Okay. So one good idea is that you can ask the child to take water and go sleep in a dark room, take a paracetamol or a Brufen at the onset of headache. Okay, if you give the medicines later, they may not work. Okay, and usually you can give 2 doses 4 hours apart. Okay, and they do work well in most of the children. But if they don't work well, then you should focus more on your prophylactic therapy. So there is a 3 to 10 rule. You should not give more than 3 days or consecutive days of these NSAIDs like Brufen or naproxen for more than 10 days in a month. If you give more than 10 days in a month, more likely the child would have a medication overuse headache. Okay, and the medication per se can cause a headache. Okay, which is a sort of a rebound headache. So this child does need lifestyle modification, okay, like a good sleep hygiene and good water and good hydration and avoiding sunlight and so on. So some of the non-pharmacological measures that we can try, as I told you, are relaxation, hypnosis, yoga, aerobic exercises, meditation, and so on. We do use a lot of nutraceuticals, especially there is encouraging evidences for riboflavin, okay. Why so? Because sometimes parents find it more acceptable that we give vitamins rather than start on topiramate, okay. So it makes my job also easy. I tell the parents, let us start on riboflavin and see what's happened. And if it doesn't work, let us put on topiramate. Okay. So the concept behind that is that there is a sort of a mitochondrial energy depletion in migraine, and this riboflavin does help, okay, to some patients. Is there evidence? There evidence is scarce, but there is some evidence for riboflavin that it works, especially when we give a good dose of 200 to 400 mg for children for around 3 to 4 months. Okay, so the vitamins therapy do work. So what we generally follow in our practice is that we give vitamins, and if vitamins fail, like riboflavin doesn't help, we start on with topiramate. Okay, so this girl can be tried on riboflavin as well. Okay, yes, doctor. Yeah.
If you can get closer to the...
Yes, we are 5 more, I think 5 more minutes, I'll be able to finish the key points, right? Thanks. So our index child had a chronic migraine, okay? So we started early prophylaxis. We started a headache diary and nutraceuticals, right? So this is what the head pain or the core concepts. Headache is common. We need to assess the pattern, primary headache or secondary headache, and then monitor with headache diary and do necessary lifestyle modification. Okay, so the interesting 2 case scenarios which I'll quickly run through is just to see that we can have some variance of headache in children. So this is a 3-year-old child who has this unusual irritability episodes lasting for 18 hours, 12 to 18 hours from 18 months of age. 1 to 3 episodes in a month. The child would cling on to the mother. The child would avoid the light. He may have vomiting. Okay, there is a strong family history of migraine. And during one such episode, the child had a neck tilt. Okay, so you can see this video where the child is, he is like extremely cranky, and he's closing his eyes. He wants to light, and there's a mild head tilt to the right side. Okay, so this is an example of a benign paroxysmal torticollis, and this child responded nicely to cyproheptadine. Okay, so benign paroxysmal torticollis is an example of migraine variant. Other could be cyclical vomiting syndrome. Okay, where there can be head tilt which can last minutes to days. You will have nausea, vomiting, irritability, and it usually resolves by around 4 to 5 years of age. Okay, so any paroxysmal episodes which comes on and off, okay, in addition to migraine, the 2 other differentials we usually think about are an epilepsy. Is it an unusual focal epilepsy, or it is usually is it a channelopathy, okay, or it is a metabolic disorder? So these are the differentials we think. I'm not going into the details, okay. So the other migraine-like episodic syndromes are cyclical vomiting syndrome, benign paroxysmal vertigo, and abdominal migraine. So one more case scenario, a thin boy with nephrogenic diabetes insipidus on hydrochlorothiazide. He had this intermittent headache from 10 years of age. Okay, it was thought to be migraine because it was episodic, it was throbbing, there was phonophobia, there was family history of migraine. Okay, but he used to have this transient blurring objects we thought it as visual aura, okay? He was started on propranolol, but what happened for this child was that he started having more headaches, which became more daily in the morning hours, with vomiting, with intense photophobia, and increase of this blurry vision, okay? So, and then he started developing squint and double vision and papilledema. So this was a child, a typical example of a progressive headache, which sort of mimicked a migraine. Okay, so this was an example of a child who had idiopathic intracranial hypertension with MRI findings suggestive of tortuosity of optic nerves, flattening of the posterior lobes, and empty cella turcica. Okay, so this child responded to topiramate and lumbar puncture. Okay, so idiopathic intracranial hypertension is a very rare, but it can be missed, especially in bigger children. It is usually seen in more in girls. They can have these transient visual obscurations, which are sudden sort of blindness or blurring of vision, which lasts for 5 to 10 seconds. Okay, but they can have early warning vomiting, diplopia, and so on. The important factor is that vision loss is a risk. Okay, if you don't treat this raised intracranial pressure, they can have secondary optic atrophy and lose their vision. Okay, so CSF manometry is very, very mandatory. Okay, and sometimes if medical measures like acetazolamide or topiramate fails, you should go for a VP shunt or CSF diversion procedures. Okay, so let's go for the Zoom polling. Dr. Zahir, shall we? Can you help me with the poll session? Yeah.
Yeah, we'll do, inshallah. Thank you.
Right. So we have a 4-year-old boy, okay, who comes in with headache. His father is asked whether a brain scan should be performed. So which of So inshallah, we'll start the poll. Right. Right.
You can answer the poll on
Yes.
the screen comes to you.
Yes. So yeah, so just the audience have started to answer. I think I just encourage most of you to just give it a try.
Yeah.
These are the topics, concepts that we discussed today. So we'll have 30 more seconds, inshallah. Right, good. Right, good. Good. Right. Okay, shall we give the answer? Yes. Yeah. So very good. Most of you have got the right answer. It is the headache that wakens him from sleep. Some of you thought, yes, probably age under 5 years is also a criteria. But as I told, some children with age less than 5 years or 6 years still can have migraine, especially if there is a positive family history of headache. But among this point, the strongest feature that favors a brain scan is a headache that wakens him from sleep. It's always a very serious cause. Shall we go to the next question, doctor? So here we have a 12-year-old girl. Okay, this girl presents to the office with headaches that makes her miss her school. Okay, and you are trying to differentiate between migraine and tension headache. Which of the feature which will help you to differentiate between a migraine headache and a tension headache? So this girl has like episodic headache. A very simple question. So which headache do you think would, which pattern would you think, or which nature would you think which help you differentiate between a migraine headache and a tension headache? Yeah. Yes, Dr. Zahir, I think we can give the answer. It's a very easy question. Most of them have got correct, right? So the answer for this, shall we stop, Dr. Zahir? Yes, good. Right. So most of you have got correct. That's good, excellent. So migraine is very typically a throbbing pain and a severe pain. Okay, so this is a feature that actually differentiates a migrainous headache from a tension headache. It is the nature of the headache. Okay, so the migraine headaches are more likely to affect girls rather than boys. Migraine headaches are more aggravated by exercise. Migraine headache does not cause a band-like pressure. It is a tension headache which causes a band-like pressure. Okay, and migraine headache does not last too much hours. Sometimes tension headache can last much more hours. It can last for even 6 days and 7 days. Okay, but migraine headaches usually last somewhere between 1 hour to 72 hours. Okay, so the next question is a 15-year-old girl is started taking medicine for acne. She presents to the office with poorly localized headaches, blurry vision, and tinnitus. Which of the following diagnoses can explain this finding? So this is the third question. So again, a very straightforward question. She's an adolescent girl, right? She takes medicine for acne and she starts developing daily headaches, which is poorly localizing. We can have 30 more seconds. She has blurry vision, okay, and she has tinnitus. So is the child having idiopathic intracranial hypertension? Is the child having medulloblastoma? Is the child having migraine? Is the child having tension headache? Or is the child having a cluster headache? Okay.
We're getting 60 around % of responses. I think we'll end it, Doctor.
Yes, we'll end it, Doctor. We'll end it, yeah. So most of you have got it correct, but I think some of you have thought about trigeminal cephalalgia. So what is this trigeminal cephalalgia or cluster headaches? Now, cluster headache are also primary headaches, okay? It also happens episodically. It is very severe, but it is very focal. It is almost never seen in children. It's very, very rare. But there will be like a conjunctival congestion. There will be redness of the eyes and there's watery eyes, and it is very severe stabbing, like unilateral facial pain. It's more of a facial pain rather than a headache, okay? And there are significant autonomic manifestations. But this child is having a daily headache. So the pattern here, it's not episodic. It is a daily headache, and she has this blurry vision, like a transient visual obscuration, and she has a pulsatile tinnitus, okay? And she started taking medications. So sometimes these idiopathic intracranial hypertensions are because of unusual medications like retinoid, like isoretinoid, which can be seen in acne creams, okay? Or it could be because of unusual vitamins like vitamin A, vitamin D, or tetracycline antibiotics. Okay, so these are some of the medications which can trigger a idiopathic intracranial hypertension. So this child had a idiopathic intracranial hypertension. So the next question is a 10-year-old girl who presents to the emergency with a headache and vomiting for several hours. The headache is frontal and it is like a heartbeat. She has to have her light out and without any noise. She has headaches like this for the last 3 years. This headache is different, that it started with numbness and tingling, okay, in her right arm, and she was confused. Her vision is normal. The symptoms resolved after 45 minutes, but the headache continued. Her blood pressure is normal. Physical and neurological examinations are normal, which is most likely in this patient. Scenario number 4. Is this child having intracranial hemorrhage? Is this child having migraine with aura? Is this child having migraine without aura? Is this child having pseudotumor cerebri? And is this child having tension headache? We'll have 1 minute for this.
Yeah. We encourage all to participate in.
Yes. All of you can just give whatever answers you feel. So that would increase our chance of discussion actually. There are no right or wrong answers. It is just that you answer as much as possible. Right. We'll have 20 more seconds for this question. Yeah, 10 seconds more. Yes, very good. Most of you are answering it. Good. Right. Okay, Dr. Zahir.
Yeah.
So, yeah. So, yes, most of you have got the answer, but there is also, a close number of them which thought that this could be migraine without aura. But these are the features, this child definitely had initially migraine without aura, but recently she started having this unusual numbness and tingling in the right arm. So aura can also be a sensory features, okay? It can be also be a speech features, or it can be also be a confusion or memory, like my memory feature. So aura can be visual, can be speech, can be sensory, and so on. So aura is any sudden unusual sensation or unusual feeling, warning sign which precedes the headache. As you can see here, the symptoms preceded the headache. But once the symptoms completely resolved after 45 minutes, her headache sort of continued. So this is another classical feature of migraine with aura, where the aura starts and the aura sort of ends, okay? But the headache would continue. As you can see, the child is not having any neurological deficits. The child is having a normal power. The blood pressure is normal. So it is not a stroke, okay? Because stroke would have some form of a deficit. It's not an epilepsy with a focal deficits where the child is having a focal towards weakness or a one-sided weakness, okay? So whenever you see this unusual sensory phenomena, in addition to migraine, the other thing that we are worried is an occipital aura of or an occipital epileptic aura. Okay, so some children with focal epilepsy, especially occipital epilepsy, can have these unusual auras, but usually that auras are visual auras, okay, which are different from migraine auras, because migraine auras usually are either like black spots like a scotoma, or they are like bright lines like a scintillating scotomas, okay, like a scintillating zigzag lines. Whereas the occipital epileptic auras are like colorful patterns of squares and round colored blobs, okay, which persist for only brief seconds. Whereas migrainous aura usually persists for minutes, whereas epileptic aura usually persists for like seconds to minutes, okay. So this child had a migraine with aura, okay. Whereas pseudotumor cerebri does not produce like these unusual sensory findings. Tension headache does not produce these sensory findings, okay. So the answer here is migraine with aura. So the last scenario is a 9-year-old girl who presents to the clinic with 1 year history of headache. So it's 1 year headache. This is having phonophobia, photophobia, nausea, vomiting, okay. But she does not have vision loss or numbness or tingling. The headache is 1 to 2 times a month after school. In between the headache, she's normal. She continues to do well in school. Her physical and neurological examination is normal. So which of the diagnostic tests is more appropriate for this particular patient? So can you start the poll? Yeah. So this is a 9-year-old girl. We'll have 30 seconds for this question.
Yeah. Of course, there's no right and wrong. I mean,
yes, there's no right or wrong.
Participation there.
Yes. Right. Okay. So this is a very straightforward and easy question. Okay. So this child is having a episodic headache for 1 year and she's well in between. You don't need electrolytes. You don't need CBC. You don't need CT scan, because the way to convince the parents is that when a child is intra-episode interval is absolutely normal, we do not need to investigate the child. Okay. So MRI is definitely not required for the child. So the answer is no further evaluation is required for this child. Okay. So a very quick summary of what we have talked today is that if you see a child with headache, the most important question is the pattern. And if you see a progressive, either if it's an acute progressive or chronic progressive, you should think about the secondary and the red flags, and you should proceed with imaging. But if you see an acute episodic headache, you should think about migraine and tension headaches, and you should start prophylaxis, especially if it is like frequent and 3 to 4 attacks in a month. You have to monitor with headache diary and drawings, okay? And if it's chronic non-progressive, again, you should think about primary headaches like migraine or tension headaches, okay? You can do necessary lifestyle modification and nutraceuticals. But if there is no response to these episodic headache, you should think about, atypical causes like migraine variants or migraine mimics, or you should think about psychological causes in the case of a chronic non-progressive headache, okay? So this is in just my message for the day. So thank you for your attention. I'm sorry for this prolonged session. It was 1 hour plus. So I'm willing and happy to take questions.
Yeah. Thank you, Dr. Mohammed. I think we'll start with the questions. And I think you have spent a good amount of calories in this session.
Right.
Yeah.
Yes.
So last few questions there. I mean, the child, is the child of less than 7 years with his headache, no migraine or migraine be at high? Would he be at high risk to develop migraine in adulthood? Like, does patient take his migraine to the adulthood?
No, if a child, so I'll try to clarify the question. The question here says that if the child is less than 7 years with history of a non-migraine, okay?
Or migraine.
Or migraine, okay.
Yeah.
See, as I told, any child who's having migraine, the way they go into becoming adults is roughly around 20% only, not more than that, okay? So most of these, around 50 to 75% of these headaches in children do resolve when the child grows up, okay? So, but around 25% of them can persist into an adult. But that doesn't, if the onset is very early, does not automatically means that the child would have migraine as an adult. I don't think so, yeah.
Yeah. The question about triptan have been, I think, answered in the presentation itself. And the question about can any, change in the status of consciousness be alarming sign of secondary headache in children despite the age of the child?
Yes, definitely. This is a very good question. Can the change of sensorium be alarming? Of course, if the child is having altered sensorium or altered awareness. Okay, that's why I opened up the topic of occipital epilepsy. Okay, so occipital epilepsy is a close migraine-like mimic because they can have visual complaints and they can have headache. But what can be associated with occipital epilepsy is these brief episodes of loss of consciousness or brief unawareness where the child looks confused. Okay, so if this child is having this confusion-like episodes or loss of awareness-like episodes, you can think about not migraine, but you can think far more like whether it's an epilepsy or whether it's a syncopal attacks, which is causing, post-syncope and headache, whether it's an orthostatic hypotension and so on. So, okay. So you need to think about secondary causes when you have other neurological symptoms like loss of consciousness. But having said that, some degree of dizziness, giddiness, and vertigo can be part of migraine itself. So you need to clarify whether it is loss of consciousness, loss of awareness, or it is like a giddiness or vertigo. You need to clarify what is exactly happening to the child. Yes.
Yeah, and the question about the infancy or the children who cannot explain their status, like like mentally challenged or unchallenged.
Yes.
How we can get the issue of headache there.
Very good question again. Very good question. How do you know infant is having a headache? So there was this interesting case series when I was a pediatric resident in India. So the government of India started giving vitamin A oil as an oil preparation, routinely along with vaccination. At the vaccination of measles at 9 months. And most of these children started having episodes of irritability and crying and refusal and vomiting and head banging episodes. So vitamin A was given at 9 months and 18 months and 2 years and so on. So as a part of government initiative, but surprisingly, most of these vitamin A given were sometimes given at wrong doses or overdoses, and it caused pseudotumor cerebri. So one of the behavior younger children or children who are like disabled or like CP is having can show is that their sleep would be affected. They would be having prolonged crying episodes. They would be having head banging episodes. They would go and bang their head in their walls. They can pull their hairs, okay, or they may have vomiting episodes. So a high index of suspicion is required for these children. And yes, for these children, further investigation can be done if we are not sure why the child is irritable. It is like approaching an irritable child, okay? So irritability is one of the hallmark for headache less in infancy, yeah. So I hope that answers the question, yeah.
Yeah, and the question about the, what is the time frame of the progression to define like acute progressive headache? What's the behavior of the headache?
No, again, that's a good question. So when we have time frames for episodic events like migraine and for tension headache. So when we see it's a progressive headache, we are not exactly talking in terms of the time frame, but we are talking about the clinical status of the child. Okay, the acute presentation, but the child also seems to be worsening in a stepwise manner, like in a staircase manner or in an everyday manner. Okay, so there is no specific time frame for an acute progressive headache. Okay, so any headache which is of sudden onset or acute onset and seems to be worsening over days, you should think about acute progressive headache. And the most common cause usually is a viral meningitis or a viral meningoencephalitis or unusual viral infections like Epstein-Barr virus. Okay. But you can, of course, you need to rule out other causes as well if you think about acute progressive headache.
Yeah, great. What about is there any serious link between the infantile colics and migraine?
Yes, it's a good question. I'm happy Dr. Tawfiq always asks very nice questions. So the infantile colic, which was a part of your episodic periodic syndromes associated with migraine, is recently been subjected to a lot of discussion, and in the ICDH-3, that particular infantile colic has been actually been removed. So because there is conflicting data, there is data suggestive that having infantile colic children can have migraine as an adults. So it is mainly subjective. So there is no conclusive evidence to say that children who have infantile colics can develop migraine in future. Okay, so it is not as of now considered as an episodic periodic syndrome associated with migraine. I hope that answers the question. Yeah.
Yeah. And are there any studies about prevalence of types of headache in Oman? The commonest type of headache.
I did get a prevalence of headache study from Kuwait, actually. Interestingly, when I was looking for it, I didn't get anything from Oman. So the prevalence of the Kuwait study is close to 30% for any headaches and 10% for migraine headache, which is almost fitting with the universal data. I didn't get any prevalence data study for Oman. I got it from Kuwait though. Yeah.
Yeah. What about meningeal sign? I mean, an irritation there in the younger age group. I mean, sometimes it's difficult to elicit.
Yes, of course. So the question is that it is very difficult in infants to understand meningeal signs and nuchal rigidity. So as I said, any child less than 12 months, okay, we have to rule out meningitis, and automatically a child less than 12 months presenting with poor feeding, irritability, refusal, we always rule out meningitis by lumbar puncture. So the clinical signs for meningeal signs are like Kernick's and Brudzinski's are much more apparent in children more than 3 years. So less than 3 years, the meningeal signs is a bit tricky. It may be difficult to elicit as well. So it is always preferable to rule out intracranial infections in smaller children with irritability. I hope that answers the question.
Yeah. What about, I mean, I think, do you see like medication overuse, headache, or the migraine transformation in pediatric age group?
Yeah, so again, the adult data does not, it's actually extrapolated to the pediatric data in terms of medication overuse, headache. So you don't have like a case series or, big studies talking about medication overuse, headache in children. Having said that, medication overuse, headache is a definitive phenomenon, especially in adolescents, okay? Bigger children who, who tend to take paracetamol and brufen even without parental consent, isn't it? So this entity is definitely there, okay? Medication overuse, headache, but we don't have the bigger studies to validate them,
Yeah. About the, I mean, does aura proceed headaches? I mean, is it always, I think you already touched about the aura and headache. It's not always to have an aura with the headache, is it?
Yeah. So aura, if it's a migraine with aura, usually the aura is followed by headache, okay? There is a very rare condition where you can have just aura without headache, but that's a very controversial entity for migraine. But whenever we say classical migraine with aura, the aura is almost always followed by headache, usually 30 minutes or 45 minutes into an aura. But if you have only auras, you should think about transient ischemic attacks or an epileptic aura rather than migraine.
Yeah. The question about cerebral palsy, patient, or he comes on of a seizure and he's already on medication and he bangs his head.
Yes.
Behavior. Do we need to evaluate more or?
Yeah, again, a very, very interesting question, and thanks for this question. Okay, so if you have a child with cerebral palsy on sodium valproate, okay, if you're having this head banging behavior or a headache, and if it's a child is already on sodium valproate, and is having these episodes, okay, so the two ways to approach is that probably the first thing I would do in my practice is that I would increase the dose of sodium valproate to maximum tolerable levels, somewhere around 40 to 50 mg per kg, and see the response. If it doesn't work for that cause, I would definitely evaluate, look for secondary causes, or I would try to do for a CSF to measure the opening pressure. If the child is a bigger child, of course, or I would try to go for topiramate and add and see and what is happening, because topiramate is also a good drug for these children. Okay.
Yeah.
So it's a basic practice. I mean, there is no specific, definitive answers for that. It depends upon that individual case of child with CP. Yes.
Yeah. About the cluster headache, which is like a bit less seen in pediatric age group. Yes. Any like medication?
Yes. So cluster headache is very, very rare. Okay. If I remember, I just remember only one child. And there are responses to indomethacin for cluster headache in children. But otherwise, these children need to be given any NSAIDs like brufen or ketorolac or naproxen and so on. So, but indomethacin is said to be better in children, but I don't have any personal experiences with cluster headache.
Yeah. About the, case of like cyclical vomiting.
Vomiting syndrome. Yes. So cyclical vomiting syndrome is a very, very interesting syndrome. Okay. There are definitive criteria is that the child should have multiple vomitings within 1 hour. They should have at least 4 episodes of vomiting within 1 hour. And the distance between one episode to the next episode should be, gap should be at least like 1 week. Okay. And it should happen for a period of months. And if there is a strong family history of migraine, we can always think about this entity of cyclical vomiting syndrome. Okay. But having said that, it is a diagnosis of exclusion. Okay, you need to involve our pediatric gastroenterology colleagues. We need to rule out rule out the other causes for this episodic vomiting. We need to look for the endoscopy. Okay, and if you think about metabolic causes, you need to work out for that. But in the presence of strong family history of migraine, it's a good idea to start anti-prophylactic medications like cyproheptadine, or sometimes coenzyme Q or topiramate. These medications do help in children with cyclical vomiting syndrome.
Yeah, there's some voted questions, I mean, about the, I mean, in case of child allergic to ibuprofen,
yes.
and already taken like paracetamol, what other, I mean?
Yeah, naproxen. Naproxen is a very good drug as an NSAID. Okay, but see, if I want to go for a safer bet, I would give a higher dose of paracetamol. So slightly higher doses of paracetamol up to 20 mg per kg. Okay, in terms of pediatrics, it's said to be as equally effective like NSAID. Okay, though NSAID may be slightly more better than paracetamol. So if I want to be safe, I would try a slightly higher dose of paracetamol like 20 mg per kg instead of Brufen and C. And if it doesn't work, I would try naproxen for these abortive attacks for headaches.
Yeah. What about, I mean, video games? Can it cause different types of headaches, or it is like migraine type, or?
No, that's nothing like a definitive correlation between different types of headache. Video games can aggravate all types of headache. Mostly, I would believe it aggravates your tension headaches because that will be an uneasy sensation over the head, and the child would be a bit cranky. But if there is a family history of migraine, or the child is predisposed to migraine, video games can trigger an attack of migraine as well. Okay, so video games and this mobile and TV screen, the guidelines, the recommendation is that do not use them for more than 20 to 30 minutes at a time. So after 20 minutes, it's better to give a break for around 2 to 3 hours, and then the child may be advised to use them again, not continuously. And sleep is very important. Sleep deprivation. Generally, these children who play video games and mobiles also do not sleep in the night properly. Okay, so that can aggravate their headaches.
Could it also, I mean, stimulate epilepsy?
Yeah, so epilepsy, there is an entity called reflex epilepsies, which is a type of generalized epilepsy which can be aggravated with the light, any form of light, like a flickering lights. So video games can have sort of a flickering lights, okay, which can aggravate your photosensitive reflex epilepsies in a specific subset of people. Having said, reflex epilepsies are rare. There are reflex epilepsies like hot water epilepsies, eating epilepsies, which is seen in Sri Lanka. Food bowlers can trigger an epilepsy. So this epilepsy can be very, very notorious and tricky. Yes. Yeah.
There's one case, I mean, from Dr. Hind, about 7 months age boy with torticollis intermittent, without any like irritability, etc. How you approach? Is it a migraine?
Yes, I agree. Yeah, agree. This particular, so benign paroxysmal torticollis starts from 6 months to somewhere between 2 years onset and disappears by 4 years of age. I agree, a child is having episodic torticollis, or it could be a benign paroxysmal torticollis, which is considered as a seizure mimic as well, okay? But if the child is otherwise developmentally normal, okay, without any other neurological features, and if there are like a suggestive family history of migraine, we can think this child is having benign paroxysmal torticollis, and we can try on cyproheptadine or astazolamide or any other medications. Agree with that. It could be benign paroxysmal torticollis.
Yeah. A question from Dr. Faisal.
Yes.
About, I mean, is migraine cocktail a common practice in?
Yeah, status migrainosus. Yeah, so I didn't go about status migrainosus. So status migrainosus for the audience is a condition when the migraine attack, it gets prolonged more than 3 days and does not respond to your common NSAIDs or paracetamol, okay, and the child inevitably ends up in the emergency room, okay. It is a very severe form of headache. So migraine cocktail is actually advised from the adult studies. So there are, like, they say cocktail 1, cocktail 2, cocktail 3, and so on, okay. So cocktail 1 is usually IV ketorolac with IV prochlorperazine, okay, and a good amount of bed rest and IV hydration. And cocktail 2 is a addition of sodium valproate and dexamethasone. And cocktail 3 becomes dihydroergotamine or a continuous infusion of sodium valproate and so and so. Okay, so these are very rare cases, status migrainosus. Having said that, if you are able to put the child in a dark room, even in the hospital, okay, put him in a dark room, avoid people talking with them, less noises, give a good degree of hydration, some mild degree of sedation with antihistamines like diphenhydramine or chlorpheniramine maleate, okay, and around the clock NSAIDs, they do respond, okay. So those extreme cases of very severe status migrainosus are almost very rare in children.
Yeah, there's some question or a comment on the chat about prophylaxis. Can we use, I mean, amitriptyline in migraine variant?
In migraine variant? Cyclical vomiting. Yes. Even amitriptyline can be tried in a cyclical vomiting syndrome. So as I told, so it is my practice to involve my pediatric gastroenterology colleagues and where I had practiced before, we had more comfortable with cyproheptadine, but amitriptyline can also be used. Okay, coenzyme can be used. Even topiramate can be used. So I had one child who responded only to topiramate, and had failed even amitriptyline and cyproheptadine. So I'm not aware which is better, whether amitriptyline is better than cyproheptadine for cyclical vomiting. I'm not aware of that exactly. So these agents can be tried, yeah, for sure.
Yeah. The question about hemiplegic migraine here, I mean, is
yes,
it common? Do you see it? How do you evaluate it?
So ultimately, epilepsy, migraine is nothing but a channelopathies. So the hypothesis is that these channels in the brain, sodium channels, potassium channels, and calcium channels, okay, are the ones which cause those episodic phenomena, be it epilepsy, be it migraine, or be it other channelopathies like episodic ataxias or paroxysmal dyskinesias and so and so. So there is hemiplegic migraine is again another unusual syndrome. It comes under the category of complicated migraines. I didn't go into the details of complicated migraines, okay, where children can present with unusual episodes of weakness on one side with irritability, especially small infants between 1 to 3 years of age. And they are related to sodium channels and ATP channels and calcium channels. These are very rare, but if you have these sort of unexplained episodes of weakness and irritability, you should always think about migraine, complicated migraine like hemiplegic migraine, and a genetic workup, a trial of astazolamide, trial of topiramate may help. Okay, so these are unusual cases. We do have cases even in Royal Hospital. There are at least like 3 children with hemiplegic migraine following up with Dr. Nabil. Okay, so these are rare, but these can be seen. Yes, once in a while you can see hemiplegic migraines as well. Yeah.
Okay, we'll go for more 2 questions. Then we'll, I think, we'll give Dr. Abdul Asmi a small speech after these 2 questions. I mean, about how did you feel? I mean, about giant cell arthritis and headache. I mean.
No, not at all. No, not at all. Giant cell arthritis is not at all a pediatric condition. At least that much I can confidently say. It is, to my knowledge, I don't think it is a giant cell arthritis is a pediatric condition. It is a disease of adults. So I've not been exposed to a giant cell arthritis in my life. So I will not be able to answer that question. Yeah.
Yeah, I mean, like one voted question about from Faisal. What is the BBV and MBV of sneezing aggravated headache?
I mean, this
was brain tumor.
Yeah, sneezing aggravated headache and diagnosing brain tumor is very interesting for me, actually, to be very honest. So what we know is that the cough or straining or Valsalva maneuver or posture or change in posture, cough, and all these things indicates intracranial pressure. Okay. What is the positive predictive value and what is the negative predictive value? I'm not sure of that particular thing, especially sneeze aggravated headache. Yeah.
Yeah, great. Dr. I mean, just Tawfiq is commenting that, I mean, pediatricians are avoiding amitriptyline because of the
constipation,
side effect dizziness coming. And also, sometimes they get more, patients get more, I mean, less active with the amitriptyline.
Yes.
So they try to avoid it on this issue.
So amitriptyline, personally, it is very useful for bigger adolescents with, with the depression or mood disorders. So those children, it is useful to be started as a prophylactic agent. Okay.
Yeah.
But in adults, it is much more useful to start amitriptyline, especially for, I believe so, especially for those who have mood disorders. Children, of course, it's a tricky drug because of the side effects. Even though the risk of arrhythmias is less, but and constipation and other side effects, we generally tend to avoid amitriptyline. Yeah.
Yeah. Thank you. I think we'll stop here from the questions. Thank you, Dr. Muhammad. I think you have done a great job. A lot of thanks to you in the chat areas, and it is interesting and eye-opener for, I mean, primary healthcare physicians. And you have done 3 presentations in one talk, where the adult colleagues are doing, I mean,
so I think that's the main message in pediatrics. Pediatrics can have everything an adult can have.
Yeah. Right. So, I mean, can we invite Dr. Al-Asmi, Abdullah?
Yes. Yes.
To give some small few remarks. This is the 4th session of the headache, which is the final session. Of course, we are thanking the Oman Neurology Society for their efforts to organize the sessions. And we are looking forward for more sessions on like epilepsy and other conditions here. And also we thank Dakhlya Primary Healthcare Committee with the Oman Family Medicine Society. Dr. Abdullah, do you have some words or?
Yeah, sure. Thank you, Dr. Zahir. It was really an excellent experience. I would definitely like to thank you and your team on behalf of the Oman Neurology Society. Very well organized society, yourself and your team, very professional in dealing with, and definitely I think looking at the feedback I received, it was a very successful series, and you know, the talks are usually allocated 40 minutes, but then they go on and on, which also reflect the interest of the participants. The questions were excellent and very practical. So thank you for giving us this opportunity. And I hope that in the future, we're going to have maybe other series. I think epilepsy will be one we can organize at one point when your schedule permit. I think what we have learned over the last 4 weeks or so, when we talked about all these different types of headaches, adults, and then Dr. Akbar today with the pediatric, I think it's very important to go back to the basic, very important history taking, details, very basic neurological examination. I think general examination, blood pressure measurement, fundoscopic exam, making sure there is no focal sign. These are very basic things. And then at the primary health setting, I think you also have the opportunity of seeing the patient also in follow-up because the patient is living very close by. And this is also will give assurance for the patient and also for the doctor in case something he missed. We are all available. I mean, we are all colleagues, friends, you know, available. Feel free for people to contact us in case they need opinions, either directly or through WhatsApp and so on. When we are always there to help. I think Dr. Zahir and your team is very important now to work towards further improvements, the care a family physician can provide for these patients. Yeah. Especially now with increasing number of family doctors working in primary health setting, in polyclinics and so on, with an excellent training. I think you can handle most of the common cases, either initially or later when they get referred back from the specialist. I think the health centers maybe need to be upgraded in terms of what medications available for such patients. And I think this will be your role, Zahir, and your colleagues to go and talk to the decision makers, Ministry of Health. And it's very important when we talk about a headache where you need to have some options for abortive therapy as well as for some basic preventive therapy. And I don't think every single patient who comes in with headache need to be seen by a specialist, at least not at the beginning. And you've seen how common this condition, and definitely there are no enough neurologists around, either adult or pediatric, to handle all those cases. So I think this is one of the things maybe I would really request you and your colleague to take it up, and we are there to help. You had an idea of developing some guidelines, not an issue, and we'll take it from there. I really enjoy this interaction and this collaboration, and we are all looking forward for more interaction with our colleagues and friends in primary healthcare setting. Thank you, Zahir, again.
Yeah, thank you, Dr. Abdullah, for your cooperation and your colleagues, pediatricians, and pediatric neurologists and the adult counterpart also. And it is a learning also. We got a good chance to get together And this AIIMS will get us more, in touch to, with different specialties. So the communication, sometimes we can do like more approaches so we can get more communication. Either we can do, in the future, we can think of like video conferencing between primary healthcare and you as a neurologist, instead of, referring the patient physically. So we can invent more, idea. As I said, this series has highlighted the need to do like a national guideline on headache, and some of our colleagues there already thinking of to start like a small group. Either we can take it from the Family Medicine Society, and we can approach, Ministry of Health and our colleagues in other, academic institution like the Sultan Qaboos University. And it is a fruitful, of course. And thanks for all your team members, Dr. Abdullah, and for backing us and also in some of the technical issues there. Thanks, Dr. Mohammed, for your time spent with us. It was very enjoyable, very fruitful, and a lot of thanks. A question, Dr. Mohammed, can people get your slides?
Yeah. I can make it as a PDF copy and share to you, and that can be shared. No issues.
Yeah.
Okay.
So we'll share the slides with the email when you get your certificate.
Yes.
Inshallah, within 4 days, we'll get your certificate. When you close the window, the Zoom will get like a link to the same evaluation. So please fill it up so we can process easily the certificate on this issue. You'll get also the YouTube video, which will be put on our Oman Family Medicine Society Twitter, or you can access it on our also Oman Family Society YouTube channel. And also you can access our Dr. Akbar also YouTube channel. He's also a YouTuber, a medical YouTuber. Hope you can get more serious, Dr. Mohammed.
Yes.
Any final comments, Dr. Mohammed?
No, thank you for this opportunity. I'm really happy for the audience participation. It's a very good initiative. So as you rightly said, we need more such sessions. Primarily, I think epilepsy is a good idea. So giving very clear concepts about epilepsy would help our referral basis and treatment outcomes actually. Yeah. So I think that's a good idea.
Yes. Yeah, great. Yeah. Okay. Thank you all,
so much.
Dr. Mohammed.
Okay.
We will end our session and enjoy your time. And
thank you so much. Thank you so much to all the participants who are coming here. Yeah. Thank
Goodbye. Assalamu alaikum.
Wa alaikum.
We are closing now, and enjoy your time.
Thank you so much.
Thanks a lot. Bye.